So my presentation will be about assisted ventilation in patients with ARDS, in particular the role of NAVA. So these are my disclosures. And I think everybody in this room is aware of the fact that there are benefits of assisted ventilation. As has been shown this morning, I mean, assisted modes prevent the development of disuse atrophy of the diaphragm, and disuse atrophy of the diaphragm is associated with adverse outcome. So that's a good reason to use an assisted mode, right? It has been shown, and we all are aware as clinicians, that assisted modes may improve oxygenation. And a lot of you might have seen this video, but it's very illustrative. I mean, this is under conditions of controlled mechanical ventilation. And as you will see, there is development of atelectasis right here. While when we are using the diaphragm, we're actually recruiting the lung. And of course, this will reduce shunt fraction and improve oxygenation. So another reason that we might consider assisted mode for ventilation. Assisted modes of ventilation allow lower interthoracic pressure, which will improve hemodynamics, as has been shown in several studies. And finally, assisted modes usually require less sedation and will result in a more physiological breathing pattern. So why are we not using an assisted mode in all patients? Well, this has been pointed out repeatedly. It increases the risk of higher tidal volumes and higher lung distending pressures. But the question is, if we decide to use an assisted mode, is there a role for NAVA or not? So first, one slide on the physiology again, because that's important right here. If in a patient on pressure support, we increase the level of support to 10, 20, 30, it will increase tidal volume up to a level where the thoracic cage limits further increase in tidal volume, right? But the situation is a little bit different in NAVA, as shown by data by Lucas Brander. Increasing the assist with NAVA increases tidal volume initially until, at least in most patients, more or less a plateau develops. And this is the result of vagal reflexes, the hearing-Breuer reflex most likely. So because of these different physiological backgrounds, we decided to develop this physiological study. So we tested 3 modes of assisted ventilation: assist control, pressure control ventilation, where the patient has the ability to trigger the ventilator, but is not in control anymore after that. The patient can't control the duration of inspiration or the level of support. While in pressure support, the patient has a little bit more freedom, has more or less the ability to affect the inspiration time, whereas during NAVA, the patient has the ability to control more or less the inspiration time and the level of support. So increasing freedom to control the ventilator from left to right for the patient. Each mode was applied for 30 minutes, so it's a physiological study to help us to understand what's happening in randomized order. PF ratio of the patients, on average 140, PEEP of 14, and FiO2 of 0.6. So first, important, I guess, tidal volume, pressure control, pressure support, and NAVA. And on average, the tidal volume was the same in the 3 groups. So even if the patient has more freedom to control the ventilator, tidal volumes are more or less protective, except for this cage, which I will discuss a little bit later on. So what about airway pressure? Peak airway pressure, not significantly different between groups. Perhaps more importantly, of course, the mean airway pressure that better reflects alveolar pressure. Well, it was indeed a little bit lower in NAVA, and that, of course, is the result of the waveform of the pressure delivered. Where in pressure control and pressure support is more a square waved form, whereas during NAVA there's a more gradual increase in pressure, so the mean airway pressure will be lower. Although, well, the question is if it's a clinically significant change. What about patient effort? The change in esophageal pressure in these patients, well, again, significantly lower in pressure support and NAVA, so the patient is putting more effort in there. If you compare to pressure control, but still the differences are small again. And that's the same thing for the mean esophageal pressure during the inspiration. Again, a little bit more effort in pressure support and NAVA in these patients compared to pressure control, but I don't think the differences are that large. So this is the important thing, I guess, the transpulmonary pressures. And this is the transpulmonary pressures in comparison to baseline. So it's not a total transpulmonary pressure, but it's a transpulmonary pressure as from baseline. So it doesn't really include the PEEP. But right here, although the peak transpulmonary pressure is a bit higher in pressure support and NAVA, the absolute difference is only 1 centimeter of water. So that's not, I guess, clinically important. And again, the mean change in transpulmonary pressure, which again is more important, I guess, was a little bit lower in NAVA compared to pressure support, but not really different. So I think the conclusion for the first part must be that in all assisted modes that we tested, they're all, well, as protective. Not really a difference in the way they are protective. So if there's no difference at this level in the way we can deliver protective ventilation, what about the patient-ventilator interaction? And this is a rather complicated figure, perhaps. What it shows here for pressure control is the coefficient of variation of electrical activity. So there's quite a lot of variability in the EDI in these patients, while the variability in tidal volume is not that large. But that's what we recognize because the patient cannot really regulate his tidal volume in pressure control. Again, in pressure support, the variability in EDI is the same, so the ventilator doesn't really affect the variability in EDI, but now there's more variability in the tidal volume, and as expected, it's even much better in NAVA. So changes in EDI are reflected in changes in tidal volume during NAVA. So, well, you are aware of this. The trigger delay, of course, better in NAVA compared to pressure support and pressure control. This has been shown a few times during this conference, but focus on this. So what about cycle of delay? And we can discuss this later on, why this happened, but cycle of delay was much higher in pressure control, 265 milliseconds, compared to NAVA, and even the difference between pressure support and NAVA was significantly different. So there was a problem in cycling off, both in pressure support and in particular pressure control. And the interesting thing is this important or not? So this is a rather complicated slide, but I try to get you through it. So what it shows right here is the pressure time product, so the area under the curve of the transpulmonary pressure. And we divided the inspiration in 3 parts. So the part where there is triggering, but the ventilator not activated. The part of the inspiration when the ventilator is activated and there is neural inspiration from the patient. And the part where there is cycle off delay. So the ventilator is still active, but neural inspiration has ended. And now, if you look at this part, so the PTP-TP, I know it's terrible, but PTP-TP, there's no difference between the groups here, and it's very small. In the synchrony phase, so in the phase when the patient and the ventilator, there's no difference between the groups. But now look right here, during the cycle of error period, the PTP-TP is much larger for pressure control as compared to NAVA, and there's even a little bit of a difference in pressure support. So in the phase of cycling of error, there's lung distending pressures during assisted ventilation in these patients. So it looks like that the fixed duration that is delivered with pressure control and more or less with pressure support is perhaps less lung protective. And I think that fits very well with the editorial written by Art Slutsky a few years ago, that asynchronous indeed can induce higher lung distending pressures. Well, you've seen this slide. There is an association between adverse outcome and patient ventilator asynchrony, so perhaps these findings are important, but it doesn't really prove, and at least our study doesn't prove that. It does show that it happens. So to conclude this first part, I think we show that increasing freedom to control the ventilator provides, from physiological perspective, a protective ventilation, and that it improves patient-ventilator interaction. So just to come back to this one patient, as you probably expected, this patient appeared to have a pretty low pH, so a terribly high drive. And I think we all agree that these patients shouldn't be at assisted ventilation at all, because that's probably the explanation for the Papazian paper that showed that these patients should be in the early phase on muscle relaxants. So the thing I pointed out here, I guess, is the importance, and I pointed out yesterday as well, is the importance of the diaphragm-lung interaction. And we now realize that we didn't pay too much attention to it in the program, and we should have, but this is really important. The action of the respiratory muscles on the lung distending pressures, and I think I can recommend you to read these two papers, but I'm a little bit biased, as you can see. And we had discussed it briefly yesterday. I think Ewan was asking the question, are we able to measure these kind of pressures in clinical care? And I told you, we are not doing it in a routine base. But in a patient, when you think there's a high respiratory drive, it is not that difficult. I mean, it's different from scientific perspective. If you want to know if the esophageal pressure is -5 or -6, but from a clinical perspective, I can just show you here. So this is, of course, arterial pressure. This is esophageal pressure. This is gastric pressure in a patient, and in this case, I thought it was a volume-controlled ventilation. It's rather easy to see changes in esophageal pressure, and we're just using the pressure transducer you're using for the arterial blood pressure measurements as well. So I think this might be helpful, although you have to be careful in the interpretation of the conclusions. So I think I've shown you that in patients with ARDS and a normal respiratory drive, an assisted mode for ventilation is indeed feasible. There's not really a difference in assisted modes on tidal volume or transpulmonary pressure, either pressure control, pressure support, or NAVA, but more freedom to control the ventilator results in a better patient-ventilator interaction. Okay, thank you very much.
Any questions from the audience? Thank you very much, Leo. I had one question. Oh, Laurent?
Thanks, Leo. It was very good. Maybe one comment, brief comment and a question. The comment is the official abbreviation for transpulmonary is L for lung, so that would help you to say PTPL.
It's easy to pronounce, yes.
And the question is about the variability. You know that there are proposals for having noisy ventilation, or and there are some data suggesting that with NAVA sometimes you observe a better oxygenation, which may be related to this variability. Did you observe such a difference in oxygenation or gas exchange?
Yes, I think, I didn't show the data right here, but during NAVA, there was a little bit better oxygenation. I think there was a difference of 1 kilopascal, so yes, indeed that's the case. Although CO2 was a little bit higher, but yes, there was a little bit increase in oxygenation, a little bit better oxygenation with NAVA compared to the other two modes. That's right.
It's interesting because it seems to be a consistent findings across very different studies.
Yeah, right.
Leo, can I ask one quick question? In your study in patients with ARDS, the major difference was related to the end of the inspiration. And so a lot depends on what your cycle-off criteria are and how you define end of neural inspiration, correct?
Yeah.
So can you talk about the sensitivity of that, and is there a potential issue with that? Because we don't really know when the end of neural inspiration is.
That's right. I mean, we did quite some thinking how we should determine the duration of inspiration and pressure control, and what we did is we decided not to use the EDI signal to determine the duration of the inspiratory time in pressure control, because normally if you are in assisted pressure control, you don't have this signal available. So we used a kind of setting that would be used by clinicians. And in this case, we decided to put the mandatory rate amount around 5 beats per minute lowered, so the mandatory rate about 5 lower than the spontaneous rate of the patient. And then, because our ventilators have a fixed EI ratio, this determined the inspiration time, actually.
Great. Thank you very much, Leo.
Good.